We're covering the pathophysiology of abdominal pain, clinical evaluation and history, physical exam findings, high-yield diagnostics, a deep dive into appendicitis, and we'll wrap up with other major surgical emergencies.
Section 1, the pathophysiology of abdominal pain. To get this right, you really have to understand where the pain is actually coming from. Because if you understand the origin, the diagnosis usually reveals itself.
The absolutely crucial point here is nailing the distinction between visceral and parietal pain. Visceral pain, it's poorly localized. It's deep, dull, and vague, usually triggered by inflammation, ischemia, or something like distension. But parietal pain is a whole different beast. It's well localized right to a distinct abdominal quadrant. It's sharp, severe, and triggered by direct irritation of the parietal peritoneum. When a patient's pain shifts from visceral to parietal, it's usually signaling a localized inflammatory process, and that literally screams surgical emergency.
Anatomically, this maps out in a really fascinating way. Visceral pain maps vaguely to the midline. So epigastric pain correlates with foregut structures like the stomach or biliary tract. Periumbilical pain, that maps to the midgut, like your small bowel and appendix. And suprapubic pain aligns with hindgut structures. Conversely, parietal pain localizes directly to specific anatomical quadrants based on whatever underlying organ is actually inflamed. Catching that transition from midline vague pain to a specific quadrant is a massive clinical clue.
Moving on to Section 2. Clinical evaluation and history. Let's see how gathering the exact right clues sets up your entire diagnostic pathway.
When you're taking a history, onset timings are pure exam gold. You've got to memorize these. A sudden, seconds-long onset, that points to a total catastrophe, like a perforated viscus, a ruptured aneurysm, or acute mesenteric occlusion. Now, rapid acceleration over minutes suggests colic syndromes. Think biliary or ureter stones or ischemia. But a gradual onset, building over hours, points you toward an inflammatory process, like appendicitis or cholecystitis. Also, pay attention to the character of the pain. Colicky, waxing, and waning pain indicates smooth muscle contracting against an obstruction, whereas severe, persistent pain usually means you're dealing with infection or inflammation.
The chronology of nausea and vomiting is another massive clue. You really need to pay close attention to this timeline. If the patient vomits after the pain starts, you should highly suspect appendicitis. But if the vomiting precedes the pain, you're likely looking at food poisoning or gastroenteritis. And if that vomit is bilious, well, you know right away you've got an obstruction distal to the duodenum.
Section 3, physical examination findings. This is where your hands confirm exactly what the history just suggested.
There are a few high-yield eponymous signs you just have to know cold because they give away the exact anatomical position of an inflamed organ. First up, the obturator sign. That's hypogastric pain triggered by internal and external hip rotation, which strongly suggests a pelvic appendix or an obturator hernia. Then we have the iliopsoas sign, evoked by hyperextending the right thigh. That points directly to a retrocecal appendicitis irritating the iliopsoas muscle. The Rovsing sign is always a fascinating one. You palpate the left lower quadrant, but it actually produces pain in the right lower quadrant, confirming right-sided inflammation. And finally, the Murphy sign. That's an inspiratory arrest caused by pain when you palpate the right upper quadrant, a total classic for acute cholecystitis.
Section 4, high-yield diagnostics. In the acute setting, every single lab and scan you order has to have a clear clinical indication so you can minimize both time and morbidity.
Think about the branching logic in a standard diagnostic algorithm for acute abdominal pain. If you've got a patient with sudden onset pain, unstable vitals, and peritonitis, you go straight down the resuscitation and emergent surgical exploration pathway. You completely bypass advanced imaging. There's no time for it. But if they're stable, then you can follow the alternate pathway into targeted imaging and labs.
For your lab workup, a leukocyte count over 10,000 with a left shift, which just means an increase in immature white blood cells, is a massive red flag for inflammation, even if their total white count looks normal. Lactic acid is your go-to marker for tissue hypoxia. If you see ongoing elevation despite resuscitation, you're looking at progressive tissue ischemia. For the urinalysis, pyuria or hematuria often points to UTIs or stones, but be careful here. Up to 25% of appendicitis cases can actually have pyuria if the appendix happens to be resting near the bladder. Oh, and never ever forget to order a beta HCG pregnancy test in all women of childbearing age. It's absolutely mandatory, no exceptions.
When it comes to imaging, upright chest x-rays are your best rapid screen for free intraperitoneal air, which you'll spot sitting right under the diaphragm.
Ultrasounds are fantastic for the biliary tract and ovaries, and obviously it's your go-to choice if you're trying to avoid radiation in kids and pregnant patients. But CT scans? Those are your definitive workhorses. With IV and oral contrast, a CT scan diagnoses appendicitis with incredible accuracy. We're talking 94% sensitivity and 95% specificity. Finally, MRI is generally reserved for pregnant women presenting with acute pelvic pain when an ultrasound just isn't giving you a clear answer.
Section 5. Our Appendicitis Deep Dive. Let's really zero in on the most common urgent surgical procedure you'll see. The timeline of acute appendicitis perfectly maps back to the pathophysiology we discussed earlier. Watch how it evolves. From 0 to 12 hours, appendiceal obstruction causes distension. That creates that dull, visceral, periumbilical discomfort and anorexia. As venous congestion worsens between 12 and 24 hours, the inflammation extends transmurally. It finally touches the parietal peritoneum and boom, the pain shifts to sharp parietal right lower quadrant pain, usually accompanied by nausea and vomiting. If this is left to persist beyond 24 hours without intervention, the risk of appendiceal perforation and diffuse peritonitis absolutely skyrockets.
Special populations will absolutely trip you up on exams and out in the clinic. Remember, pediatric patients often present atypically. 40% have no anorexia, and over half show no rebound tenderness. You really have to rely heavily on ultrasound first to spare them the radiation. Now, for pregnant patients, this is actually the most common non-gynecologic emergency, occurring in about 1 out of every 1,500 pregnancies. Fever is often completely absent, and a laparoscopic appendectomy is considered perfectly safe and indicated immediately. Standard treatment across the board is IV fluid prep, a preoperative second-generation cephalosporin, and the appendectomy itself. But pay attention to the abscess management protocol. If a patient comes in with a well-localized abscess, they might just get IV antibiotics and a percutaneous drain, which is then followed by an elective interval appendectomy 6 to 12 weeks later once all that inflammation has fully cooled down.
Section 6. Other surgical emergencies. Finally, we need to briefly contrast appendicitis with a few other lethal intra-abdominal catastrophes that you need to be able to spot instantly.
There is a stark contrast between these major upper abdominal issues. Acute cholecystitis builds steadily. Typically, a patient eats a heavy, fatty meal, and then 4 to 6 hours later, they develop right upper quadrant pain and a positive Murphy sign. On the flip side, a perforated peptic ulcer, which is frequently linked to chronic NSAID use, strikes like a sudden bolt of lightning. The patient feels immediate, severe epigastric pain that rapidly progresses to a rigid abdomen and diffuse peritonitis.
Down in the vascular system, the presentations are just as dramatic. If a patient, especially one with a history of atrial fibrillation, comes in with severe, constant pain that seems totally out of proportion to what you're finding on your physical exam, you've got to think mesenteric ischemia right away. Keep an eye out for that rising lactic acid. But if a patient presents with sudden abdominal pain radiating straight through to their back or flank, accompanied by a tender pulsatile abdominal mass, and they're in shock, you are dealing with a ruptured abdominal aortic aneurysm.
I'll leave you with this high-stakes scenario pulled straight from clinical practice questions. You're faced with an 84-year-old male who suddenly becomes unresponsive 2 hours after complaining of acute abdominal pain. What is your very first algorithmic move to save his life? Do you rush him to CT? Do you prep for surgery? Think back to our diagnostic algorithm. The answer isn't a scan. It's getting immediate IV access, obtaining stat lab values, and starting aggressive fluid resuscitation while you secure his airway. In the acute abdomen, your ultimate priority is always stabilization before definitive diagnosis. But this leaves us with a critical dilemma for your future practice. When stabilization fails and the clock is ticking, how do you decide when it's time to blindly open the abdomen versus when to hold off? Think about exactly where you draw that line.